Mark Nelson is a consultant physician at the Chelsea and Westminster Hospital, London. He is a professor of HIV medicine at the Imperial College Medical School, where he is also the senior tutor. Professor Nelson has built a large HIV practice with a special interest in patient care, co-infection with hepatitis B and C, and the clinical utility of new drugs. He has published over 650 papers on HIV and hepatitis. Mark has chaired the BIVA Guidelines Committee for Opportunistic Infections and for Hepatitis C, and was previously the chair of the BIVA Hepatitis Special Interest Group and the Science and Educational Committee. He is a member of the Guidelines Committee for Treatment Malignancy and for HIV Transmission. He is a trustee of several HIV-associated charities and has been awarded a visiting professorship at the Aga Khan Hospital, Nairobi, Kenya, and most recently, the Certificate of Merit by the Government of Vietnam. We are delighted to have Mark provide highlights from the International Workshop on Innovations in Delivery of Care. Mark?
Hello, my name's Mark Nelson. I'm Professor of HIV Medicine at Chelsea and Westminster Hospital in London, and also the Professor at Imperial College London. And it was my great delight to be the Programme Director in the first conference on innovations in the delivery of HIV care. And I think, first of all, I'd like to say that we've come a long way. You know, the way that we give care and deliver care has been fantastic. And we've really moulded that over a relatively short time to really deliver great care to those individuals living with HIV. But I think we all need to think all of the time how we can do things better. Certainly, this conference was actually thought about pre-COVID, but became more important post-COVID. And it's important to look back at history and look how pandemics have actually shaped the world we live in. This is the first Greek plague, the plague of Athens, which was probably due to measles, but probably also led to the fall and decline of the Greek Empire. Similarly, the Roman Empire really started to go downhill after the Antonine plagues, probably due to typhus and measles. And if we look at Europe, the bubonic plagues, the Black Death, really led to the end of the feudal system in Europe. So looking back at history, pandemics have really shaped the world that we live in. And so it should come as no surprise that the coronavirus will also change the way that we live, not only in medicine, not only in HIV, but also the way that the whole world functions. And so what I think we need to do is realise that we are giving great care, but actually review that care, review how we deliver care, review how we give care to those individuals living with HIV. Now, certainly the pharmaceutical companies, despite the COVID pandemic, have continued to fulfil their and our wish to pack our pipeline ever more deeply with more and more choices to actually allow us to give the individual living with HIV in front of us a great deal of choice about what treatments they wish to receive. But what we need to do is take a step back. We need to think about how we are going to give the right care. How are we going to give it in the right time? And also, how are we going to deliver great care to individuals not only in the hospital setting, but also in other settings, and more in primary care and in the community. And we have to realise all the time that we can do better and strive to do better for the patients who we are looking after. As I say, over the last 40 years, there have been great improvements in HIV service delivery. We've gone away from the traditional centralised hospital model. And perhaps due to the fact that we're given a target, this target of 90-90-90, which is actually increased, of course, to 95-95-95 or even greater, we've changed the way that we deliver care from this centralised hospital model to a much more client-centred approach, a much more community approach, integrating technology, task shifting and task sharing. It's gone away from it just being the doctor delivering care to actually very, very positively other individuals giving care, maybe nurses, maybe pharmacists, maybe other individuals. And of course, we've also learned the lesson of the need for a rights-based system of care and equity in delivering care to all individuals living in HIV. And this must be multi-secretarial and comprehensive. And of course, COVID may have changed that. COVID influenced this, and perhaps it affected many of these community-based organizations rather than the traditional-based. And we need to look at the messages that have come through from COVID, which are given to us from what patients want from their care, what we've learned makes good care, about making sure we don't just move back to this hospital model, but actually move much more, I think, into the community, much more into task shifting and task sharing. This is just an example given at the conference by Linda Gale-Becker of the disruption that COVID caused to HIV programs in sub-Saharan Africa. And if you look at changes in mortality due to ART interruption, due to lack of monitoring of HIV disease with viral load and CD4 count, you can see the changes in mortality secondary to COVID. And if we look at the incidence of HIV, similarly, COVID impacted here. Again, we see the dangers of ART interruption and transmission. We know all about U equals U, but we also know that if you don't have an undetectable viral load, the risk of transmission, and also the availability of condoms due to COVID. So, COVID does show us how well we're doing and how if we don't continue to give great care, it's going to come back and bite us and our patients. And again, if we look at HIV testing during the COVID epidemic, we can see how this fell in Africa and in Asia. And of course, this is going to have an influence again on on our HIV epidemic. If we are not testing, we can't get people on treatment. If we can't get people on treatment, they may get sick. They may actually infect other individuals. But during COVID, it was not only bad news. As I say, I think we had many lessons in COVID, which actually allows us to think about how we deliver care in the future. And again, these are some examples from sub-Saharan Africa, of groups of healthcare worker managed groups, not doctor managed groups, but much more task shifting approach. An example that was given was adherence clubs, much more client managed groups. And I'll come back to this later with a great example from Asia that was given at the conference, but client groups managing the care of individuals living with HIV. Also in facility-based, in individuals who are looked after in the hospital setting, again, multiple changes, much less monitoring, much less appointments needed. And again, things such as fast-track ART refill collection within the facility as another example of improvements in delivery of care in Africa. And in those individuals living in the community, again, many groups actually, because individuals were unwilling or unable to travel to the hospital, there was much more mobile outreach, much more community-based antiretroviral delivery. So we mustn't just look at COVID as a negative thing. We need to look at the positive things which came out of this pandemic as regards delivery of antiretroviral care. Where it's available, much more telephonic consultations, and also innovations in actually being able to actually look at the patient. Here's an example called Dot, which allowed individuals during the COVID pandemic to actually, during a telephonic consultation, to have their heart rates, oxygen saturation measured. And again, we need to embrace telephonic consultations. For us, patients traveling 2 hours to be told your viral load is undetectable and you're well, and followed by an hour's queue in the pharmacy. All of this can be done remotely by telephonic consultations. Now, of course, part of the worry in the hospital setting may be, if we do more telephonic consultations, we move things into the community, are there going to be jobs for us? And we need to take a step back and realize it's not about us, it's about the patient. Again, another example from sub-Saharan Africa, looking at the use of robots to deliver COVID relief. But again, how do we use such technology to actually improve HIV care in the future? Certainly, as regards mHealth, COVID-19 accelerated the healthcare towards a virtual world. And what we need to think about is not how do we not use this, but how do we embrace it and use it in a positive way? And it's not only about how we deliver HIV care, but also about delivery of research. And Marta Bafito, who I work with here, gave a fascinating talk about, how we can actually deliver research remotely and how COVID has really driven that, the use of e-consent, virtual consultations rather than having to come to the research unit, home testing. More and more we have point of care tests for many of the tests that we will do within both research and within HIV care, medication shipments. So it's not just about how we deliver care to the individual, but how do we deliver research in the future? And clearly, again, the COVID-19 pandemic did drive the way we delivered research using master protocols, much more coordinated, much more collaborative approach. So instead of units actually in competition with each other, actually units now coming together to give research in various different areas into a much larger group of individuals. What we do need to make sure, though, that these opportunities, as we grow innovative ways of running research in the resource-rich world, that it doesn't mean that we do less research in low-resource regions. So the first session, which looked at the changes which should happen post-COVID, the main messages were really that digital approaches are going to increase, not decrease, patient engagement, not only in testing services, but also in services which deliver HIV care. But if we look at things such as self-testing, these are really going to improve in the community setting. They're going to move it away from the hospital approach, much more into a community setting. And we need to ensure that digital and decentralized approaches, we are also aware of their potential perils. And these need to have careful consideration. We can't just move straight into a digital world. We need to think about the perils of these innovations as well. We need to think about equity. We need to make sure that these are available and affordable to all. We need to make sure that there's no coercion. You must do this approach. We need to make sure, particularly with marginalized groups, that they aren't disempowered and they aren't lost to the services. We need to make sure that there is linkage to care. As an example, will individuals who test HIV negative therefore not seek clinical services thereafter? I'm going to be well for the rest of my life. We need to make sure that they are sustainable, and we need to be able to audit these innovations and make sure that they are being used appropriately and properly by individuals. And I mean individuals who are delivering care and those individuals who are receiving care. Again, the next session really looked at new technologies, looking at new technologies for delivering both PrEP and antiretroviral care. And certainly many of the innovations in HIV drugs are looking at different delivery methods. And we heard all about the possibility of intramuscular injections, monthly pills, or even longer, long-acting subcutaneous injections, vaginal rings, subdermal implants, microneedle drug patches. There are a lot of ways that HIV drugs can be delivered. In fact, all drugs could be delivered, and we're going to have more and more choices for the individual. And so just some of the examples, and I don't really want to go into the details of these studies, but cabotegravir, you all will be available, you all know will or is available as a long-acting suspension via intramuscular injections. And there's positive data both in treatment, but also in PrEP. And if we look at study HPTN 084, we actually see that the cabotegravir given as an intramuscular agent was actually even more successful than Truvada. So we have very positive data on cabotegravir. Islatravir is going to be available as a monthly pill. So it's going to give us an opportunity both potentially for PrEP and for treatment to give an individual a monthly pill. Clearly, we need something to actually partner this with. I think having a pill which is one monthly and something else which you have to take once a day is not particularly useful. But the idea of actually moving away from daily pills to taking something less frequently. And again, islatravir as a long-acting implant, particularly in PrEP, you may be able to get away with this implant being changed once a year. So big changes on the horizon. Again, Gilead had this agent, lenacapavir, which is a caspid inhibitor, again given by subcutaneous injection, and again being studied as regards PrEP, and as treatment as regards PrEP may well be able to be delivered every 3 months. So we have this massive antiretroviral drug delivery pipeline, and it's about how are we going to integrate this into the way we deliver care, because we're going to have to change the way potentially that we deliver care. If we're putting implants in once a year for PrEP, that's going to change the way we deliver PrEP. If we're actually giving intramuscular injections perhaps every 2 to 3 months for individuals to treat HIV, again, it's going to change the way that we deliver care. So there are massive opportunities, but there are also multiple challenges. And if we look at the challenges to the systems we work with, there's the potential of, as regards intramuscular injections, at least larger number of visits. But as we move on to yearly PrEP, potentially with some of these implants, it may actually reduce the number of appointments. The type of appointment, the duration of appointment is going to change if we have to give intramuscular injections and perhaps look at the patient afterwards. We need to think about how we're going to deliver these services. Where are we going to deliver services as regards PrEP particularly? Is it going to be community-based pharmacies? Many clinics now have mobile health vans, or even can we have in-home services, i.e. individuals being visited in their homes? And the one thing missing here is the potential to use this in primary care. And I think more and more that when I look at the data which is available, the type of care that we're giving, more and more I think we've got to move away from hospital-based care to primary care being the centre of the care for individuals living with HIV. We also need to make sure that we are tracking injections, we have retention systems, and of course, in many countries, there may be issues as regards supply chain and logistics. And remember, these drugs which are given every 2 months or 6 months or yearly are going to have very long half-lives. So, if we're not able to provide the drugs due to difficulties in supply chains, there's the difficulty of drug level decay to such a level where the individual will be at risk of HIV and at risk of developing resistance if they acquire HIV. There are going to be challenges at the provider level as well. How do we, as we've said, interface with the various different health systems? How do we actually train individuals? How do we make individuals aware of these opportunities in giving care? And again, it all comes back to health inequities as well. And then, of course, there's product level challenges. How safe are they? Yes, they've all been through clinical trials, but we're aware that with every drug we give, after a few years, we go, oh, we found a new toxicity. If you're giving something which is long-acting, particularly as an intramuscular injection, it's there. If you've got the toxicity, you can't remove it. And that may be the advantage of implants. We need to think about adherence to these products, as I've said. Discretion as well. Coming to a clinic specifically to have an injection really may give the game away as regards diagnosis or that an individual is receiving PrEP. And I've already talked about the potential hazards of the long PK tail. And then we have client level challenges as well. We need to make sure that individuals are aware of their options. One of the great things about HIV care is that we don't dictate what the patient should take. We give the individual options, and we need to make sure at the client level that we're clear about the possible benefits and risks, and make sure that we are making a decision together which is right for the individual sitting in front of us. So it all sounds great, doesn't it? We have high levels of undetectable, we have increasing amounts of numbers and choices of drugs that we can give. The game's over, isn't it? But this was a nice talk which came about, what's happening in Asia and the Pacific. And you can see, if you look at 90, it just isn't being achieved there. And these gaps as regards testing, engagement in care, and getting people on treatment and being virally suppressed are actually quite huge. And if we look at HIV testing, we can see in countries such as Malaysia, Indonesia, and Afghanistan, large number of individuals who are aware of their HIV status but aren't on treatment. We can see that many countries still do not use the kind of test and treat approach. So there's quite a long way to go in this region, particularly in some of the countries. You can see other countries such as Cambodia, 100% of individuals aware of their HIV status and on treatment. If we look at our coverage and the number of individuals who are actually on treatment, again, you can see the region lagging behind. And there are many barriers, and one of the important barriers which was put forward in the region is this idea of legal capacity consent to an HIV test and the impact of age, and that individuals who are young are unable to acquire an HIV test legally. There are also other barriers, multiple barriers in this region as regards social justice, or indeed social injustice, the lack of human rights, and how this leads to problems in addressing health needs. You can see here some of the examples. 2 out of 5 female sex workers forced to have sex in India. 1 out of 3 men who have sex with men avoid seeking health care due to stigma in Myanmar. 2 out of 3 women who use drugs have unmet needs for reproductive health care in Malaysia. And you can see one in 5 transgender women being denied or thrown out of housing in their lifetime. So there are many, many barriers. It's not just about getting the drugs there, getting HIV tests there. It's also about making sure that there is social justice and human rights. And again, if you look at the region, you can see the number of countries that criminalize sex work, criminalize same-sex relationships. And so a great deal of work is needed, not only at the community, at the hospital level, but also at the government level to improve the way that we can deliver care in this region. And there are multiple barriers, as I've said, to enabling environment. But perhaps the biggest is stigma and discrimination. You may be aware we also run conferences in various regions, and it's amazing to hear some of the stories 40 years on in HIV of how individuals living with HIV continue to be stigma and discriminated against. The high out-of-pocket expenses keep the most vulnerable away from seeking services, and treatment regimens used are often not the most effective known in these resource-poor areas. So we do have a long way to go. I think we can't sit here in the resource-rich world in our ivory towers thinking how great everything is. We need to look at a much more global level. But there is some great news as well. So that was rather negative. And I think the conference was actually about being positive and looking about how things have changed. This is from the Ukraine, looking at rehabilitation centres and how things have changed. This is a new rehabilitation centre which has happened during the time of COVID for individuals with who are drug using, recreational drug using, putting together diagnostics and help as regards both mental and physical health, infectious diseases, HIV, looking at detoxification, looking at rehabilitation, and then continuing programs in the outpatient setting, using specific programs to the individual and group therapy, using family therapy to prevent relapses. And I would ask you to go and look at this talk. Fantastic talk about, I think about, Eastern Europe, about having a very negative approach to HIV and to drug use. It's really changing, and this is a great example of how things are changed. Also, with drug users, a very good talk from Baltimore, looking at how they've gone into the community. It's not about waiting for the community to come to us, but going into the community. There was a great deal of mistrust in the drug using population with health services, but going there with mobile vans, offering syringes, point of HIV and sexually transmitted infection testing, ad hoc wound care navigation, and COVID vaccination. And the really important message is it's trust in the community that makes the difference. We can all go out with a van, but if that community doesn't trust us, it's not going to make a difference. And other key populations were also looked at, and how we need to, how we can innovate delivery of care in those individuals. And when we do that with key populations, who are often those populations who are most stigmatized, most marginalized against, we need to make sure that these services are accessible, they're located in hotspots, they're flexible, and that they're one stop. We need to make sure that they are available to the needs of the population. It's no use us saying, oh, we will deliver this kind of care. It's what are the needs of that population, which needs to be defined by the population itself. Often the staff members need to be acceptable, and I'll come back to that in just a few moments. And we need to make sure that the quality of care that we give is of a very high standard and isn't below what can be achieved in the hospital setting. So here's a great example. This I think is an amazing clinic from Thailand. This is the Tangerine Community Health Clinic, and it's for trans specific individuals. And what was happening, there was a great deal of stigmatization, discrimination, and indeed unavailability to the trans population. So what the Tangerine Clinic actually set up, and this used members of the community as well as senior health professionals such as Professor Fanafak and his daughter. But it led to this clinic actually being led by the trans population. So it was the trans population delivering the care to the trans population to try and get rid of the stigma and discrimination which was coming from other parts and other populations. And this gives a comprehensive care to the individual, not only HIV care, but sexual health service, hormone services, and other well-being services, including addressing issues with mental health. And you can see how successful this clinic was. You can see the high number of clients that it has, the high achievement as regards HIV testing, delivering HIV care, delivering PrEP, delivering sexual health care. And again, I'd strongly recommend you to go and listen to the talk, which is available on the Virology Education website, because this is a fantastic idea of, instead of having individuals discriminating, get that population to deliver that care. It takes a lot of work, a lot of training, but you can see the positive results that come out of it. Similarly, an example from Zimbabwe, looking at care being delivered by community adolescent treatment supporters and young mentor mothers, over 2,000 of them, but giving support to over 64,000 children and adolescents living with HIV, and showing by actually using these community-led populations that you can improve adherence, you can improve viral suppression, you can improve retention, and not only that, but it can improve physical and mental health as well. Finally, Gary Whitlock, who I work with here, told us about 56 Dean Street. This is a clinic which has really innovated sexual health and HIV care. And the objectives of the clinic is to really try and give much better care, innovate new ways of delivering care, both as regards PrEP, HIV, and also sexual health. And it has two clinics. The one on the left actually delivers HIV care, sexual health care for individuals who are symptomatic. And then this really innovative approach called Dean Street Express, which looks at a novel way of actually testing individuals for HIV and sexual health. And this is Dean Street Express, and you see it looks like something out of a Star Trek movie. You know, it's right in the centre of Soho, right in the centre of central London, right in the centre of the MSM community. So it's easy to get to for individuals, and it's also, as you can see, very welcoming. And it doesn't need doctors or nurses. There's self-registration. There's a self-taken sexual health history. There's video-guided self-sampling. All right, so no doctors or nurses, no receptionist. You do it all yourself. There's then barcode scanning into a Cefiad machine, and then your results are delivered to you by text a couple of hours later. If it's positive, you're told what to do. You'll come to Dean Street, to the actual clinic. But if it's all negative, you're free to go. And so this is a really innovative approach. And it's an example of making things lean. I think that's what's going to come in the future as we have these innovations in care that we're all aware of. We're going to make it easier and more simple for the individual requiring care for us. My last message is this. I keep on hearing, as we came to the end of the COVID epidemic, from people I work with, when are we going to go back to the good old days, the days before COVID? You know, the book clinics, people coming every 6 months, having their tests done. And we've got to remember those weren't the good old days. We've got to look at the future. We've got to look at how we innovate care and take all the messages that we've learnt over the last 2 years to deliver excellent care to the individual living with HIV. So please go and look at the lectures on the website. I've only given you a snapshot, as I say, and I really hope that some of you, if not all of you, will join us next year for the second conference on this very exciting approach to HIV care.